And thank you very much. So Tuesday topics today, just a spattering of information about some new criteria or new ideas in cardiopulmonary resuscitation post cardiac arrest. So we're going to think about a couple of different aspects and have just a very, very actually quick discussion of a couple of different criteria and different methods for managing our patients when we talk about CPR. And again, always remembering that we might have a wide variety of folks who are attending, but we're not really talking about writing the order, but being knowledgeable about changes in cardiac arrest, changes in the way that we do things, and thinking about some of the methods that we employ when we care for patients with cardiac arrest. So very first, I'm just going to start with epinephrine. Epinephrine tends to be a drug that is used very aggressively in cardiac arrest, but it is really embedded in our ECLS algorithms. It's embedded in our practice. It's a go-to agent that we utilize pretty aggressively when we're talking about cardiac arrest patients. But first, I just want to share with you this editorial that just tells us that even with this was a relatively small study. It was not a randomized prospective trial, but it actually evaluated the long-term effects associated with the utilization of epinephrine. So very important to see that it actually, this editorial discussed the current literature and the fact that in the current literature, the utilization of epinephrine and more aggressive dosing of epinephrine in cardiac arrest and post-cardiac arrest led to an improvement in immediate survival, but a reduction in a retrieval, particularly of kidney injury and neurologic outcome. Now, there's been a lot of studies and a lot of publications in the years 2021 and 2022. This one, which I think is just a fabulous trial, said that even though we've been using epi, it increases the likelihood of return of spontaneous circulation, but it impairs cerebral microcirculatory flow. Now, if we just remember that saving you from a cardiac arrest is not nearly as important as saving you from a cardiac arrest with preserved neurologic function. And that's our goal. That's why we use TTM. We're really trying to resuscitate you neurologically as well as your cardiac system. So very important in this evaluation, this small trial says that, okay, short-term survival with epinephrine is improved, but long-term outcome is lessened with the use of epinephrine. Now, that doesn't mean go to your shelf and throw all your epinephrine away. It means that you're applying epinephrine with caution, that you're going to be aware that utilizing epinephrine to prepare the myocardium for receipt of an electrical defibrillation is one thing. Maintaining patients on epinephrine is quite another. A really nice trial here, this is published in January 2022 in Pharmacology, showed that an accumulated epinephrine dose associated with acute kidney injury following resuscitation in cardiac arrest patients, and followed by another trial that was published in 2022 in intensive care medicine, that cardiologists and intensivists need to be clear that their patients may do better with norepinephrine rather than epinephrine for post-resuscitation shock, particularly in out-of-hospital cardiac arrest. And that's really what this all boils down to, is cardiac arrest. So remembering that in cardiac arrest, you have a primary goal, which is to actually reinitiate the rhythm and the contractile capability of the myocardium. And your secondary goal is to preserve neurologic function. So now all this data is coming to light that this aggressive use of epinephrine in out-of-hospital cardiac arrest, both bolus and continuous maintenance strips of epinephrine, may actually be linked to much poorer neurologic outcome. So I'm not saying go back and change everything in your institution. If you're interested in some of these trials, I'll send them to you. I'm happy to do that. Just reach out to me, bmclean1@gmh.edu, and I will send them to you as soon as I possibly can. But I do think it's something to discuss and to remember, depending on where you were, that you have a lot of autonomy in dialing up on vasopressor agents. Just remember that utilizing epinephrine may be associated with poor neurologic outcome, and we're going to be concerned about that. Now, secondly, TTM. So I want to remind you about TTM, targeted temperature management. We really don't call it therapeutic hypothermia anymore. We talk about a target. Okay, so for many people, the first target was between 32 and 34. For us, that was 33 degrees. And then in around 2017, some folks changed their target to 36 degrees. We did not. We stayed at 33. And then in 2022, really 2021, many individuals changed their target to 37 degrees. So here at my hospital, we use 33 degrees for out-of-hospital cardiac arrest, 37 degrees for in-hospital cardiac arrest. And we can really appreciate that across all resuscitation guidelines, TTM, aka therapeutic hypothermia, is part of a best practice, high quality resuscitation post-cardiac arrest. Now, what started that were just two relatively small trials, but we've done lots of observational studies, and the most recent trial, which is the TIMI-2 trial, or TTM trial, not TIMI-2, that's cardiac, the TTM trial that was published in 2021, which actually said there was little difference between 33 degrees, 36 degrees, and 37 degrees, really is a game changer for all of us, because what it really means is no matter where you are, you never want to let your patients get febrile. You never want to let patients get hot. You never want to let them produce heat. I am not here to tell you that one way is better than another. Our TTM group believes that 33 degrees still has the best data, and that's what we're staying with for out-of-hospital cardiac arrest. Now, let me explain why that is. That if you have, if we cannot validate that you have had high-quality cardiac compression, meaning bystander CPR or medical CPR, we believe that we get better neuroprotection with 33 degrees. If you've been in the hospital and you have a cardiac arrest and resuscitation is begun immediately, our assumption is that that's high quality compressions. And so you actually have flow. So no flow states, that's basically what we're calling it. No flow states, we initiate TTM at 33 degrees, and we're going to assume no flow with out-of-hospital cardiac arrest. Low flow states, that's what we're going to associate with inpatient cardiac arrest. You still have flow, and therefore the projectile quality doesn't need to be quite as intensive, and we'll put you at 37 degrees. No one really says, absolutely, this is better than that. In the TTM trial, so this is very important for you to appreciate, the TTM trial, that's Nielsen's trial that was published in 2021, released in 2021. Unfortunately for them, unfortunately for the rest of us in the world, they had a very homogeneous group of individuals that they actually enrolled in their TTM trial. And by saying that, what I want you to appreciate, it's not about gender, race, identity. Homogeneous was that in those European centers and in Australia, bystanders, children, everyone is taught CPR. So bystander CPR is initiated almost immediately and is sustained, and it's a relatively high quality CPR. 97% of the patients in those trials actually had received bystander CPR, and those patients then received in hospital. They were randomized to a group of 33 to 36 versus 37, and there was no difference in outcomes. So it's a non-negative trial, meaning it wasn't better and it wasn't worse. The difference was, of course, with 37 degrees is nurse intensivity is reduced and bleeding and coagulopathy is reduced, and the patient doesn't require quite as aggressive management of sedation, analgesia, and perhaps paralytics. So very important to appreciate, especially in the practice at my institution at Grady, because we have physicians that come from a lot of different medical training and from different perspectives, that they might say, well, 37 degrees is better. It was shown to be not any worse, and therefore it's much better to put patients at 37 degrees. It's always important to remember this. In that trial, the majority of patients received high quality bystander CPR, and therefore they had low flow state versus no flow state. So very important to appreciate that difference when you're having a discussion. Obviously, in the end, although we have very rigorous protocols, obviously in the end, as always, the physician gets to make their decision about what they wish to do. Now, I want you to remember the reason we do TTM, just like the reason we should be concerned about high dose epinephrine. We use TTM not to restore your cardiac function, but to protect your brain. So whenever you have no flow states and you have a profound ischemic or infarctive type of injury that's occurring cerebrally, what happens is the cells, of course, become dysfunctional. They lose their structural integrity. It damages the working part of the cell, the mitochondria, and you release excitotoxic neurotransmitters. So all those cells that are ischemic release these neurotransmitters that then communicate programmed cell death. That's called apoptosis. So the most important one is glutamate, secondly, aspartate, and third, ionized calcium. Now, once we restore perfusion, so remember that's in a no flow state. Once we restore perfusion, you start to distribute those neurotransmitters, those excitotoxic neurotransmitters throughout the cerebral vault to other cells. And so that extends the neurologic damage that may have been somewhat limited with the initial event, but now is being spread throughout the cerebral tissue. So what we know is reducing your temperature protects you from this distribution of excitotoxic neurotransmitters, because quite honestly, you're reducing cerebral metabolic oxygen requirement. So significantly protecting those cells, which actually in the beginning were not profoundly disturbed, you're protecting them from that distribution of the excitotoxic neurotransmitters. That's what TTM does. And that's why we really want to initiate it early, why we want to have a rigorous protocol and a methodology that is not actually dependent on someone's personal opinion, but is dependent on the evidence and dependent on the science. So I referred before to the TTM trial 2, 2021. Nielsen is, you'll see him here as the last author, but it was his trial, his funding, and it was based on his TTM first trial, which was 33 versus 36. Now, this trial says normothermia after out-of-hospital cardiac arrest. So let me caution a few things. When we're thinking about TTM, we talk about what is your target, okay? So really important to say, what is your target? Target is 37 or your target is 33. In either case, you have to be concerned about certain criteria that occur. And what I want you to remember in TTM, your number one goal across both platforms, so whatever it is you choose, 33, 37, 36, your number one goal is to prevent your patient from getting hot and from producing heat. So preventing them from a fever and preventing them from shivering and seizing, because all of that produces heat. And the hotter the environment, the more neurologic dysfunction. Okay. So again, I just want to make sure you appreciate here that in this trial, it was 1,400 patients across 14 countries. I think the United States enrolled 1, and it was an out-of-hospital presumed cardiac arrest. Looking at 33 degrees versus 37 degrees did not actually significantly affect the functional outcomes. Now, that's really important because those individuals who don't want to bother with just kind of the intensivity and the consumption of putting patients in a cooler state are going to say, yeah, well, there's no difference. Well, then you didn't read the whole study. If you don't read the whole study, you just read the highlights, it's going to sound like there's no difference. But indeed, there is a difference. And I've shared that with you just a bit, because remember, what we're looking at is low flow versus no flow patients. And reminding ourselves that 97% of the patients that were enrolled, that's why the United States didn't have many, had high quality out of hospital bystander CPR. So if you have bystander CPR, you really can have some protection from this dysfunction that occurs neurologically. So that's really, really important to remember, because if we have patients that did not receive bystander CPR, we're going to use, in our hospital, we're going to use 33 degrees. That's going to give you a higher level of protection when you had a no flow state. That's really important. But across all temperatures, 33 and 37 or 36, whatever temperature you're using, you have to also be aware about these kinds of things that occur. So your cardiac arrest protocol is actually going to be applied in the same way, from my point of view, the same way across whatever your targeted temperature is. That's really important. And the single most important issue is that you've got to be able to differentiate all of this, right? So arrhythmias, hyperglycemia, electrolyte disorders, coagulopathy, alterations in drug metabolism, risk of infection, cold diuresis, that occurs more at colder temperatures. But shivering occurs whenever you are applying a therapeutic regimen to keep your patient's temperature either normal or lower than normal, which means that the bedside nurse must be vigilant. Doesn't matter. I'm not asking you to do things the way I believe or the way our team believes. I'm asking you to recognize that whenever you are applying a strategy to keep a patient at a certain temperature, so if it's 37, 37.5, 36, or 33, you are always going to be concerned about heat production, and particularly related to fever and shivering. Shivering occurs at all targeted temperatures. So by the way, just because you're putting a patient at 37 degrees doesn't mean that you don't need to be concerned about shivering. Now, the most basic method for controlling shivering is the application of Tylenol and buspirone, and that's gonna help your patient reduce shivering and therefore reduce heat production. You may also consider sedation, and as you get colder, you're going to consider some alpha antagonists. That's going to be Precedex. And if you're using a cooler temperature, much colder temperature, or 36 degrees, you may actually use neuromuscular paralytics. So really important to remind yourself that across all temperatures, no matter what, 37, 36, 33, always have to be concerned about shivering. Okay, so really, really important that in terms of looking at TTM post-cardiac arrest, you've got to really be aggressive in monitoring your patients. You're going to watch your patient's temperature, and you're going to watch, for us, you're going to watch your water temperature. No matter what method you're using, intravascular cooling, Arctic sun, blanketrol, you're going to watch the patient temperature and the cooling temperature. If that's the water temperature or the gel temperature or whatever you're using. Always watch for that. Anytime you have a drop in water temperature to below 12 degrees Celsius, your patient's producing heat. And that means that the machine, the device, is working extraordinarily hard to keep your patient cool, and your patient is producing heat. Your role, your goal is to figure out why a patient is producing heat. Are they shivering? Are they seizing? Or are they infected? Those are the big three: shiver, seizing, infection. And a lot of times shivering is micro shivering. So in my institution, if you are at 33 degrees, you're going to receive 24 hours of a continuous EEG so that we can evaluate whether or not you're seizing or you're shivering, because oftentimes shivering is subclinical, as is seizing. So we really like that EEG to give us that good information. Now, what I want you to see here is, and again, I'm not advocating for any device. This is just what we use, and this is what I have to show you. So here's the patient. This patient is kept at 37.5. This is a normothermia patient, but you can see your patient's temp starts to go up. So the water temperature, which is in blue, drops. Patient's temp starts to come down, the water temperature will come back up. And the reason it does that is to keep you within a standard deviation of around 0.5 at 37 degrees. So you can see water temperature goes up, goes down, goes up, goes down, goes up, goes down. And that's all active in order to keep your patient's temperature controlled. Now you see right here, the water temperature is 10.6. Your patient's making heat. So treating them with a cooling method is not the only appropriate therapy. You got to figure out what they're doing, shivering, seizing, or infection. Whenever that water temperature drops, you have to go to the bedside and say, what is happening? Is my patient infected? Is he shivering? Is he seizing? And what am I going to do about it? Because this kind of variability, which is fantastic, is telling you that you have a secondary problem that is putting your patient's brain at risk. You're putting their brain at risk. Now I'm going to show you another patient here. And you can see this is really nice. This is 33 degrees, and your patient has a standard deviation of about 0.5 degrees. So 33.5 and 32.5, 33.5, 32.5, and the water temperature goes up and down and up and down and up and down in order to control the patient. Now we're looking at that water temperature as we're rewarming the patient, but you're going to see it right here. It goes up and down and up and down, and it does that pretty aggressively. Now the nurse's responsibility is to assure that everything that can be done to help control the patient's temperature has been done. That's why we start with Tylenol and buspirone, which is anti-shivering. Tylenol, of course, being antipyretic. And then we look at additional methodologies to control shivering. If your patient's infected, of course, you need to be on a broad spectrum antibiotic, etc. Got to control why it is that the patient's creating heat. And the big three again: infection, shiver, seize. Control it. Now I'm going to show you this one. This is such an interesting one. You can see here that this was a neuro patient. This was not a TTM patient, but just really important to see what happens here is the patient is hyperthermic. So the water temperature drops down below 9 to cool the patient. The patient gets cool. Then the nurse has turned off the device. Turns off, that's what these red lines mean. Nurse keeps turning the device off because they're kind of concerned that the water temperature has dropped. And as soon as they turn the device off, the patient's temperature goes up again. They restart the device, the water temperature drops because they got to keep the patient cool, and turn off again. The patient's temp goes back up, and you can see all this variability. So let me just say, sort of like glycemic variability, thermic variability is really, really, really injurious. Now, this was a brain injury patient. So honestly, this practice probably facilitated and worsened the brain injury of this patient. Really, really, really important for us to appreciate. When I come in the room and I see your water temperature is here, I'm like, I'm not turning off the device. I'm saying, what is wrong? Why is my patient generating heat? Now here, it's it's neurothermic. So that's really hard for us to control, but it is really important to remember every time I turn the device off, right? It's my patient's temp goes back up, down, up, down, up, down, up. And every time it goes up, it's not really that high, but it's close to 39 almost every time. Every time it goes back up, you're going to be injuring the cerebral tissue even more. So again, when you look at a patient who's on a device and that device is aggressively cooling, there's a reason for that. It's not a device dysfunction. It is aggressively cooling because your patient is producing heat. And in this case, when you're trying to protect the brain, either with cardiac arrest or TBI or whatever, refractory intracranial hypertension, if you go on and off and on and off, and patients go up and down and up and down, or patients are producing heat because they're shivering, they're seizing, or they have an infection, we're not doing a good job. So we want to really control that. And the thing about TTM is, in the end, we're gonna continue to discover things about the temperature you want to keep patients at, and that's fantastic and fabulous. But by the way, you need to participate in this. This is an active control status. And one of the things that's really important, if at all possible, is to be connected with your EMR to your device so that you're actually looking at that variability of water temperature change, okay? And actually, many protocols, and our new protocol also will say the same, is a drop in the water temperature below 33 degrees that is sustained for greater than 5 minutes, except during induction. Because in induction, we're getting that patient's temperature down really aggressively, and the water temperature will be really low. But every time that water temperature drops below 33 degrees, you're putting your patient at risk for a skin injury, and you're also not protecting their brain. So that's going to be a really important kind of addition in terms of how you look at your patient, how you communicate to your colleagues. My water temperature continues to drop. The patient's producing heat. I think it's shivering. I think it's seizing. I think it's this. I think it's that. And for us, at least with our TTM for cardiac arrest, we apply an EEG. That is not neuroprognostic. We're not trying to prognose whether or not the patient has brain function. Sometimes the EEG tech will say, well, you should have called me before you sedate him. No, I'm not talking about neuroprognostication. All I want to do is evaluate, shiver, and seize, and I can do that with the EEG. That's why we apply the EEG for 24 hours when we are inducing patients and maintaining patients at TTM. Not because I'm trying to look at neurologic function. I'm not doing that at this time. Neurologic prognostication is not done until the patient is out of TTM for at least 3 days. We don't make neuroprognostication during TTM, period, 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 slash, 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 underline, underline, underline. Stop allowing your providers to come in and say, well, I don't see anything on EEG. He must be brain dead. Let's ask the family for withdrawal. What? No. Neuroprognostication 3 days after, not during TTM and not for 3 days after. Okay, perfect. All right, now, third, ECMO, ECLS, and ECPR. Oh my God, just incredible opportunity for the future. Looking at what we're going to be able to do. This is the biggest buffalo bull in the china shop. ECMO, ECLS, and ECPR, extracorporeal, right? Extracorporeal membrane oxygenation, extracorporeal life support, excuse me, and extracorporeal CPR. So this is what the evolution is over the next few years. We hope that we'll all be able to embrace this. Start off with ECLS. It's the use of a mechanical device temporarily to support heart and lung, or both. So we can support the lung, we can support the heart, we can support both, really, during any kind of cardiopulmonary failure. Now, that means that should lead as a bridge to recovery or to transplant. So it is important to have an end goal in mind, right? In our population, I mean, we're a fantastic center that embraces persons regardless of economic capability for payment. And many of our patients don't have a home life, may not have a home life that's conducive to the management of transplants. So we have to really remember that when we start with extracorporeal life support, what is our end goal? Our end goal would be to resuscitate and recover the organ function, because many of our patients would not actually qualify for transplant. Now, there's two types of ECLS, and ECLS is extracorporeal life support. And in this case, we're talking about ECMO, but there's other ECLS, Impella, VADS, et cetera. Those are also ECLS, they're extracorporeal life support. But in ECMO, we talk about two types: veno-arterial, taking blood from the vein, basically the right atria, and putting it back into the artery. So VA ECMO bypasses the heart and the lung. VV ECMO bypasses the lung only. So VA bypassing the heart and the lung. VV ECMO bypassing the lung only. Now, we have lots of different candidates for ECLS, but here's the thing. Anybody who has severe heart or lung failure and they meet criteria that puts them at a 50% mortality risk, we have to consider the possibility of extracorporeal life support. If they're at 80% or greater mortality risk, frequently the only agency that can actually retrieve them from the mouth of death will be extracorporeal life support. So contraindications are very, very generic, right? It really depends on the individual, how long they've been sick, what are their pre-existing conditions, would they be able to have a support mechanism after recovery that will support them? Will they meet transplant criteria? What's the futility of application? And there are some relative discussions about age and size of the patient. Actually, neonatal ECMO, pediatric ECMO, very common. Actually, our pediatric colleagues do much more ECMO than adults do, and they've been doing it a lot longer than we have. So really, a lot of this is subjective. It's like, are you going to be able to sustain what you need to sustain after we remove therapy? You have to be anticoagulated. Can you maintain and sustain anticoagulation? Have you just had a head bleed? I'm not going to be able to do ECMO because I'm not going to be able to anticoagulate you. Now, I love this. This is kind of older data because this ends at 2016, but just reminding ourselves that extracorporeal life support, this data is gathered by ELSO, and ELSO is like Society of Critical Care Medicine, or ACN, is the organization to support ECMO centers. So you can see from 1990 up until 2016, there was a significant increase in centers by the year that developed in order to apply ECMO. Now, during the pandemic, that also increased. Many more centers have popped up. And I want to just say one thing really, really, really important to remember, that if you're going to do ECMO, you've got to do at least 70 ECMO per year to actually become a high quality center. You've got to do it all the time. You have to get very comfortable with it. However it is that you're going to get to that comfort level, it does actually need to be achieved. So now if we just take a look at overall outcomes and looking at patients' respiratory, cardiac, and those who receive this as a CPR tool, and we're going to talk about what that means to receive ECMO as a CPR tool. And you can see, really, we want to look at adults overall. So total number of patients, this was in 2016, is looking at patients who got ECPR, 1,100 of them, that's 39%, is a pretty good percent, actually survived ECLS. And a very big percent of that actually survived to discharge. So that's really significant, because prior to this, those patients who would have actually been impacted were all really dying. So really an important concept when we think about ECPR. Now, just as a reminder about ECMO principle, I love this little diagram. It's all about diffusion and gas exchange, just like renal replacement therapy is, just like ventilatory strategies are. It's all about how do you remove CO2 and improve oxygen. Now, remember, that's with a VV. With VA, it's how do I remove CO2 and improve oxygen and improve blood flow dynamic, because I'm bypassing the heart. So again, remember, VV is a lung bypass. VA is heart and lung bypass. You're going to say, well, that sounds like cardiopulmonary bypass. Oh, yes, of course it is. It's exactly that. It's exactly cardiopulmonary bypass. VA ECMO is exactly cardiopulmonary bypass. But most importantly, the principle is about mobilizing that blood that's returned to the right atria and removing it via a venous cannula and removing CO2 and oxygenating. And then you can return to a vein, that would be VV ECMO, that's be returned to the pulmonary vein, or to the artery, and that would be the aorta with VA ECMO. So I'm bypassing just the lung, or I'm bypassing the heart and the lung. And my primary reason is to really oxygenate the blood to improve perfusion, okay? So no absolute indications, no absolute, really depends on the institution, and a lot of different studies looking at the quality of ECMO and how does that improve our patients and what does that do. But I want you to just see this, these big old hoses. You can see this is the venous blood and this is the oxygenated blood. So let's say it this way, deoxygenated, reoxygenated, whether it's VV or VA, that's going to be the whole purpose, is to oxygenate and remove CO2. And remember, in VA ECMO, not only to oxygenate, remove CO2, but actually perfuse the system. Now, this is a really great methodology in the hands of individuals who really appreciate and understand how to do it. Let me make sure that everyone appreciates that if your center is talking about ECMO or doing ECMO, you have to have an ECMO certified individual to manage the device and a nurse, a separate nurse, to manage the patient. That means if you have a nursing generated ECMO program, you have 2 nurses per patient. If your program uses perfusionists, incorporates nurses, also incorporates respiratory therapists, there always needs to be 1 individual who is managing the device, because any tiny little kink can actually kill your patient. So you've got to be sure there's someone managing the device and someone else managing the patient. And that's really how most centers have developed their ECMO program. So again, it doesn't have to be a nurse, it can be a perfusionist, but a perfusionist who's managing it has to be there. And you also have to have a secondary device in case the first device fails. You have to have a second device to actually attach to the patient. So there are lots of intricacy in setting up a program. It takes a long time. ELSO recommends a 5-year plan before you institute. Most places now have compressed that to about a 3-year plan before institution, but you don't decide today and start tomorrow. And if you work in an institution where those kinds of things are common, think about it today, start tomorrow. Help put the brakes on that. Got to have a good plan, have to have a good training plan, have to have a good methodology, have to have enough capital to buy 2 pieces of equipment, assuring 1 is never in use when you've got a patient on ECMO, because you're going to need to use the second device if you have a failure. Now, ECMO is really a bridge. It's not a curative therapy, never is. It's a bridge to recovery. And typically we see use of ECMO to help recover patients who've had acute MIs after revascularization, myocarditis, post-cardiotomy, so after surgery. Okay. Also, if you're just trying to buy some time, trying to make a decision, can we transplant this patient? Can we get a wearable VAD? Other kinds of decisions like that. And then, of course, bridge to transplant. So very, very important for us to remind ourselves that ECMO itself is not a solution. However, applying ECMO after biventricular failure or heart failure with severe respiratory failure, mainly arrest, cardiogenic shock or arrest, ECMO can really buy time while you try to figure out okay, hope you were hearing me. Okay, so really, really important for us to remember that ECMO buys you time in CPR. And it's a really important methodology and criteria. So again, I just want to remind you, it can either be VV or VA. It just depends on where that cannula goes. And that's just something that you know. And the circuit can look in a lot of different ways. Here's one circuit. There's many different types of circuits. Here's your oxygenator. This is a Mackay device, and this is showing you the oxygenator. I personally have found, I'm not an ECMO expert. I'm certified, but I'm certified in terms of knowledge, but not in terms of practice. But I've really been studying it. I went to the ELSO basic and advanced ECMO course. I really found this to be quite simple, this Mackay device. But again, it really relies on the understanding of volume flow pressures and gas exchange and diffusion. So you have to really become comfortable with that when you're getting ready to apply ECMO and understand. So reminding ourselves that cardiac arrest is a cardiac emergency and a neurologic emergency. One of the goals in ECPR is that if we cannot return spontaneous circulation, we will consider ECMO. So I've got a 28-year-old woman who had a cardiac arrest. Let's say she had long QT syndrome, and we can't return spontaneous circulation. She becomes a candidate for VA ECMO during cardiac arrest. That decision has to be made within about 10 minutes. Or you have ROSC, return of spontaneous circulation, but you continuously arrest. So you have a return, and then 3 minutes later you arrest, and 5 minutes later you arrest, 10 minutes later you arrest, 20 minutes later you arrest. That patient actually meets criteria for ECPR. And if we know that the patient has cardiogenic shock or any other issues, very important to consider ECMO. And again, typically ECPR is VA ECMO. So that's what you'll start with in ECPR is VA ECMO, and then you will titrate to VV ECMO. And so that's really important. VA ECMO is for the worst of heart failure. And then you often will transition to VV ECMO, which is about respiratory failure. And so again, whatever the cause is. So this Newsweek was published quite a long time ago, right? In 2007. And the front cover was, "This man was dead, but he isn't anymore." And that's because, of course, he got ECPR. So the term ECPR has been evolving along with ECMO, and it's really come into fruition in publication at around 2007 when this public media campaign for ECMO was performed. So ECPR means that you begin extracorporeal life support, most particularly with ECMO, but also you could do at a much lower level with other kinds of flow devices like Impella or VAD, that you begin that during CPR. It's a CPR generated therapy. So occasionally here at Grady, we will see that patients who have cardiac arrest, who go to the cath lab, who cannot get return of spontaneous circulation, particularly if the belief is that this will not be a futile resuscitation, an Impella device will be placed in that patient during cardiac arrest while getting the CPR in order to offload the heart and maintain perfusion. Now, that is not going to maintain oxygenation, which is quite separate from what we do with VA ECMO, because remember, we take the blood out of the patient's body, oxygenate it, remove CO2, and return it. And in VA ECMO, we return it with power into the aorta. That's the flow, that's the power to actually perfuse the patient's system with highly oxygenated blood and CO2 at a lower level. So very, very, very important to remember that almost always ECPR is initiated in the emergency department. So you have a cardiac arrest patient comes in, and I'm just going to describe Grady, comes in by ambulance. They go straight into what we call the CPR room. There's 20 or 30 people there, all performing CPR. Patient's in arrest, has a return of spontaneous circulation, loses it again. You resuscitate, patient loses it again. And remembering epinephrine, remembering TTM, and then thinking about that patient, can we actually generate survival by using ECLS? Now, I'm going to share with you that I believe that the goal for my institution is to institute first VV ECMO, as everyone does, then VA ECMO, and then to actually look at ECPR. And we have a fantastic neuro-intensivist ED doctor. Oh my God, he's so brilliant. His goal is really for us to be able to eventually initiate ECLS at the bedside in the ED for refractory, that's what I'll call it, refractory cardiac arrest. Such a great idea, because it's a way that you can restore function for a patient and to be able to maintain it, because now you're providing oxygenated blood flow, not just blood flow. Impella just gives you blood flow. VADs just give you blood flow. ECMO gives you oxygenated blood flow, which is what's so fabulous about it. Okay, so basic criteria for ECPR is typically your age needs to be between 18 and 75 in an adult environment, and that we actually have a requirement, I'm not saying it's absolute, but VTAC or VFib rather than a systole or PEA, which usually has another cause, and we have to figure what that cause out is. So typically, acute heart failure, ED docs, intensivist physicians gather together, but look at this. This is time sensitive. You have to decide by 10 minutes into your code that your patient needs ECPR. And it's very similar to what we say when we talk about the cath lab. Time to an open artery should be less than 60 minutes. And here what we're going to say is time to ECMO, not cannulation, but initiation, less than 60 minutes. So that means you're still doing CPR. You might be using a Lucas device. You're doing a lot of other things. The whole time, your patient's being cannulated and placed on the ECMO device. So it's a really major commitment. But my goodness, I'm going to tell you, unless something goes really wrong, this is the wave of the future we should all be prepared for. It is the wave of the future. And what it also means is your wife or your husband or your mom, if they're under the age of 75, I've got 5 more years, they suffer a cardiac arrest, you're going to try to get the ambulance to take them to an ECMO center. Your hospital of choice may be a different hospital, but if they don't do ECMO, you need to get to an ECMO center. If possible, you're going to get to an ECMO center, because this decision has to happen while you're getting resuscitated, right? This isn't something that we can transfer you, except in a number of places. Johns Hopkins, University of Minnesota, one or two other centers now in the United States have a mobile ECMO ambulance. And that mobile ECMO ambulance actually goes out to a cardiac arrest scene, actually evaluate whether the patient meets criteria, cannulate. They have physicians, obviously. They cannulate and start on ECMO in the ambulance. Oh my God, the future is now. We really want to move forward with this because it's going to be so helpful. So if we just take a look at these, this pyramid, this is the recommendation pyramid. So you're basically saying A, B, C, D, and E. A means patient has MI or other conditions that put them at risk for cardiogenic shock, right? They don't have it, but they're at risk for development of cardiogenic shock. Sometimes that's very hard to determine unless they're in the cath lab. B, they actually have beginning cardiogenic shock. They're tachycardic with hypotension, but they're not profoundly hypoperfused. So basically for these two, right, we're just going to use medication therapy, drug therapy. And as you move forward to classical cardiogenic shock, that means a low cardiac index, low cardiac output, high filling pressure. So you're cold on the extremities and wet in the lungs and wet in your venous system, cold and wet, class 4 cardiogenic shock, also class 4 heart failure. Here's the time that we're going to start to talk about mechanical circulatory support. Mechanical circulatory support, again, means Impella or VAD with devices that actually offload the heart but don't oxygenate the blood. But if you are deteriorating from classical cardiogenic shock, or you just deteriorated from A down to significant deterioration, meaning you're not responding to pharmacologic therapies, and that's really important. You failed pharmacology. We're now going to consider MCS plus ECMO, and that's when we're going to do that. So you've got cardiogenic shock, failed pharmacology. Maybe we started with MCS, mechanical circulatory support. That'd be a balloon pump or an Impella device. You're not improving. We're going to move quickly to ECMO. We're going to try to transport you to an ECMO center, or we're going to try to provide ECMO ourselves. So that's called the DOOM, right? And then ultimately here in extremis, that's the patient that gets ECPR. They are receiving CPR. There's not really a choice for any of these other things. You actually have to choose ECMO. So remember that this is for patients who have a continuous loss of spontaneous circulation, or who you cannot recover spontaneous circulation. Those are going to be patients that we're going to consider CPR. So here you are. This is not my hospital. This is someone else's visual. This is a UCLA, I believe. And they're cannulating the patient in the ED. So they were doing CPR. They've got a Lucas device on board. They're still continuing CPR, bagging, doing compressions, and getting cannulated. And the CPR started immediately. 5 minutes collapsed till they began extracorporeal life support. So actually 45 minutes before the patient was fully cannulated and on device. So again, the reason we're going to do this, severe heart failure, hypoxic respiratory, so severe heart failure, VA ECMO, hypoxic respiratory failure due to any cause, usually ARDS, could be a PE, could be other things. We're going to really consider that we're going to utilize methodologies pretty quickly for those patients. So really vital. And again, there are no absolute contraindications. It really is subjective, right? Patients who have profound infection, and actually very rarely do individuals say we're not going to do it because they're profoundly infected. A big one though is if you're hemorrhaging. And you're hemorrhaging and it's recent or it's an expanding hemorrhage, we're not going to be able to anticoagulate you. You must be anticoagulated on ECMO. And if you have terminal malignancy or terminal central nervous system damage, we're not going to do it. But there is not an absolute age contraindication. But the older you are, the more likely it is that you're not going to do well. So again, we kind of take a look back at that whole ECPR and looking at this from 2016, reminding ourselves that 2,885, these mean refractory to the therapy that you are applying because of cardiac or respiratory arrest. Half of those patients, close to half, 40%, actually survive ECLS, and another about 4, 5, 6 eighths of those patients actually survived to discharge. So these are patients, first of all, who would have died if you hadn't initiated ECPR. And these are the patients who actually survived and went either home or were transferred to an LTAC because they were provided ECPR. This is a basic life support algorithm. This comes from the International Liaison for Cardiopulmonary Resuscitation, and the European Resuscitation Council is just a basic algorithm saying you need to make some decisions. You have to do that really, really, really quickly to make decisions about actually applying extracorporeal support. There is pretty good data that supports out-of-hospital non-surgeons introducing and cannulating patients for ECMO, some very good and even more recent data that's looking good. Hence, places like Johns Hopkins, University of Minnesota, and others are actually initiating out-of-hospital cannulation. So again, remember, VV ECMO just bypasses the lungs. VA ECMO bypasses the heart and the lungs and actually gives us an excellent supply of oxygenated blood and a lot of power. I'm going to move down to the end here. I was just going to say a few other little things, but I want to be very aware about your time. So just reminding you, blood flow for cardiac support will always be veno-arterial, and this is basic flow rates for adults, and that's really all we're talking about, 60 cc's per kilogram per minute. So a pretty high flow state, and it actually helps us to achieve perfusion. And return your venous saturation up a little bit because you're improving blood flow into the microcirculation, into the capillaries. Might take a little bit of time to do so, but you are able to do that. And then remember, VA or VB will allow you to oxygenate the blood and remove CO2, and that should be equal to what the demand of the patient is. So I just want to end here with a couple of pictures really quickly. This is, of course, a pediatric ECMO, and you can see just if we call this the pump ratio, the number of pumps equal to your risk for dying. The higher the number of pumps, the more at risk you are for not surviving. But this patient did survive, actually went home, did very well. Here's an ECPR institution in an ED, again, not RID. This patient is from UCSD. And you can see beautiful cannulation. Patient actually has 12 pumps. You can't see them. This was all done in the emergency department, and it was done by initiation was begun at around 12 minutes after arrest, and cannulation in the hands of expert cannulators and application was complete by around 40 minutes. And here's some different cannulation that can occur. All really different methodologies of cannulating patients, and they can be surgical, they can be in the ED, they can be in the ICU, they can be in the cardiac cath lab. And obviously, when you first start, you want to do it in a much more conservative way. So really quickly, just a little case study. This is a 39-year-old man, no significant history, presents to an ED with cough, body aches, headache, chills, and congestion. And he's had it for about 5 days. He's extraordinarily septic, but he also has myocardial dysfunction. He's 5 days into his sepsis. He now has myocardial dysfunction. So you see his temp is up, sats are down, has a lot of pain when he's breathing deeply, and he's hypotensive. Lactate is 4.9, creatinine is 2.32, and his EF is 40-45%. At 5:30 in the morning, so about 4 hours after he was admitted into the ED, he actually had a cardiac arrest. He was intubated, placed on a vent, 100% FiO2, and his peak was titrated quickly up to 14 in order to oxygenate him. Here's his ABGs at 10 a.m., 7.18, 51, that's his CO2. His oxygen 126, and his bicarb 18. Well, okay, bicarb's 18, he's got pretty significant metabolic acidosis, and we know that in metabolic acidosis states, particularly when your pH is less than 7.25, you might be refractory to your vasopressors. He's on norepinephrine at 12, neo at 90, they avoided epi, vaso at 0.4 units per minute, and that has ultimately brought his MAP to 65. Okay, So unfortunately, he continued to have cardiac dysfunction, requiring titration upwards of his vasopressors. So on 1252 on that same day, they initiated VA ECMO because he had a second cardiac arrest. He was really having trouble maintaining his flow and pressures. Okay, so these are just his ECMO settings. We're not going to talk about that. Okay, day 2, troponin is 28. That's high sensitivity troponin. Is 28.17. He goes to, I'm sorry, that's not high sensitivity troponin. Sorry. That's 28.17. So that's 2,817 high sensitivity troponin. Goes to the cath lab, doesn't have any disease, but his EF now is only 10%. Now that EF is 10% because he's been on all those vasopressors. He's had a lot of physiologic stress. We're going to call that stress-induced cardiomyopathy. So the goal was, let's get everything off. Let's get all those vasopressors down to off, maintaining blood flow dynamic with our ECMO. So NEO was titrated off, norepi was titrated off, and vasopressin was kept on. Patient was sedated. He's now on pressure control ventilation with PEEP of 8 and an FiO2 of 50%. Looking pretty good here. And he does indeed have very significant strep, beta strep, and severe sepsis. CRT was started on that second day. His creatinine peak was 2.64, and he started to trend down with CRT. CRT is often married to ECMO. That's often very common to perform. You're taking the blood out to oxygenate and remove CO2, and you're taking the blood out to clear the metabolic acid and the waste byproducts. But for him, the big decision was based on his refractory metabolic acidosis. Okay, so day 6, so he gets much, much better. Day 6, look at his chest x-ray. Oh my God, his chest looks terrible, terrible. So actually what happened is at that point, his blood flow dynamic had recovered significantly. They transitioned him over to VV ECMO to actually give better resuscitation to his lungs. And here he is on day 23. Look at his beautiful lungs. His heart appears to be a fairly normal size. Does have some issues here, but they're not issues that cannot be managed with his ventilator. So on day 23 in the ICU, he was decannulated, and 10 days later, so day 33, he was weaned from his ventilator and discharged to an LTAC. So thank you very much, everyone. I'm going to stay on the call, but I'm going to end the recording now, and I'll answer whatever questions I can. And thank you very much for attending on this Tuesday topic. Really, it's just some new perspectives in CPR, TTM, epinephrine, and eCPR utilizing ELS, particularly ECMO. Thank you so much. Okay.